Manipulation and stroke. Is it an effective approach to management? Over the last 3 decades, we've made substantial progress in our profession through the efforts of researchers. The conversation changed from chiropractors causing disc herniations to chiropractors managing disc herniations due to research evidence. As an example, the recent recommendations from the North American Spine Society to include manipulation as a treatment option for lumbar radiculopathy. Now, we find the same radical shift in conversation from chiropractors causing stroke to researching whether chiropractic management should be part of the treatment plan for stroke patients. Well, clearly the devil is in the details, though, because, for example, most stroke is not vertebral basilar stroke, and vertebral basilar is mainly dissection, which occurs equally as an associated risk for both chiropractors and MDs. But previously, the belief was that the associated stroke was due to atherosclerosis and that manipulation resulted in an embolism that led to ischemic stroke. Now we know it's dissection manifesting clinically as headache and/or neck pain, causing patients to seek chiropractic care while in dissection. So this next research step is a difficult one. First of all, are there evidence-based approaches that improve motor function in stroke patients? And the answer is yes, and that is physical therapy. So that when doing a comparative study, physical therapy rehabilitation must not be withheld. The consequence of that is that this is not a study of chiropractic management of stroke as a standalone, but as an adjunctive approach added to physical therapy management. So on to the study. The title is The Effects of 4 Weeks of Chiropractic Spinal Adjustments on Motor Function in People with Stroke, a randomized controlled trial published in Brain Sciences in May 2021. To be more transparent, though, the title should reflect that it is in addition to physical therapy management. And secondly, chiropractic spinal adjustments need to be clarified, which we'll do shortly. In other words, what type of an adjustment? Let's start with who and where. The study was conducted in Perth, Australia. Patient qualifications for inclusion were it had to be at least 12 weeks post-stroke, and the patient had to have completed prior hospital rehabilitation. They had to have scored less than 80 on the Fugel-Meyer assessment for motor function. We'll discuss that in a second. Patients or participants in research lingo were excluded if they had had any adverse events with chiropractic manipulation or if there were any contraindications to manipulation. What is extremely important in research is to know how you measure improvement. Patient outcomes in this study were the Fugel-Meyer assessment for motor function. We'll explain the scoring for that later. The stroke-specific quality of life scale, timed up and go and sit to stand test, and the modified Rankin scale as a measure of the severity of dysfunction. Patients were randomized into either a chiropractic plus PT group or a sham-chiropractic plus PT group. Further defined, chiropractic care in the real chiropractic group included either high-velocity, low-amplitude adjusting or instrument-assisted manipulation. For the sham chiropractic group, the substitute for HVLA was positioning but no thrust. For the instrument-adjusted group, it was the instrument set at a minimum and then clicked. Some procedure clarifications and reminders. Treatment was 3 times per week for 4 weeks, with assessments occurring at 4 and 8 weeks. Chiropractic care again was studied as adjunctive care to physical therapy. And for the real adjustive care, it's not clear what proportion of or treatments were with HVLA versus instrument-assisted. And now to the results. There were no adverse events or reports of harm during the trial. Normally, this is an expected statement, but this is extremely important to emphasize. Stroke patients in this study were not harmed by manipulation. There was considerable loss to follow-up, from 32 to 19 in the chiropractic plus PT group and 31 to 19 in the sham chiropractic and PT group. The main reason reported was caregiver availability and transportation. This small number may lead to what is called a type 2 error, which means it's unable to detect a difference between groups when one actually exists, due to too small a number of patients. So what are the categories related to the scores for the Fugl-Meyer assessment, or FMA? Anything less than 50 is severe, and anything above 95 is considered slight. Now, the FMA baseline mean, or average, for participants in this study was severe at 40.9. This is an ordinal scale with 3 points for each item. A 0 score is given for the item if the subject cannot do the task, a score of 1 is given when the task is performed partially, and a score of 2 is given when the task is performed fully. To be included in the current study, participants were required to have an FMA score of less than 80, and remember, the mean score was 40.9. In addition, the FMA calculation involves a range from 0 indicating hemiplegia to 100 points indicating normal motor performance. Then, the score is divided into 66 points for the upper extremity and 34 points for the lower extremity. In addition to motor assessment, the FMA also measures sensation, balance, joint range of motion, and joint pain. Baseline data indicated that patients were on average in their mid-50s. The vast majority were chronic stroke patients greater than 6 months, and the vast majority were ischemic stroke, as would be expected. So the first question is, could the difference between groups have occurred by chance? Well, this is determined by the p-value. Let's look at this. With the exception of the total combined FMA score and the lower extremity scores at 4 weeks specifically, all other measures did not meet statistical significance, which means statistically it is determined they might have occurred by chance. Another approach is to look at the proportion of responders using a threshold number for the FMA. As an example, if you were using a pain scale, how much improvement, or in this case, difference between groups, would indicate a level of improvement that patients would recognize as improvement. Then you calculate the percentage of responders for each group, improved and not improved. And then regardless of whether there are true differences between groups, statistical significance, or not, are the improvements clinically meaningful to the patient? This is measured by what is called a minimal clinically important difference, or MCID. So the MCID for the FMA had 2 threshold points set by the researchers. Set at 7.25 points, it resulted in 96% response for the chiropractic plus PT group and 78% for the sham plus physical therapy group. So if you lower the threshold to 4.25 points, for the chiropractic plus PT group it was 100%, and for the sham plus PT it was 63%. So the minimal clinically important difference did not meet statistical significance except at 4 weeks. Therefore, no evidence of clinical effectiveness between groups for all other measures at 4 and 8 weeks. So for the primary outcomes, significant differences between groups for motor function, primarily lower extremity, at 4 weeks were in favor of real chiropractic, but there were no significant between-group differences for all other outcomes at 8 weeks. Significant within-group differences were found with the FMA, the stroke-specific quality of life, the modified Rankin score, and the timed up and go test. However, it isn't clear whether these are clinically significant. So important points about this study are that this was a study that added chiropractic to a management approach that has demonstrated effectiveness, which should remind us that effectiveness can be demonstrated with evidence, and this is the case with physical therapy management. Also, it's interesting that patients in both groups believed they were receiving the real chiropractic treatment. Therefore, blinding was accomplished. When we look at the within-group improvements, there are absolutely improvements in both treatment groups, which begs several questions. If both groups improved, could it be due to natural history? Well, given there is no control group, nor can there be one ethically, we don't know the answer. If the sham group improvement was clear but simply not quite as much as the real treatment group, there are a couple of possibilities. Is it because real chiropractic is no more effective than sham? And is the improvement then just because of the physical therapy and perhaps natural history? These questions become the germinal components of the discussion for the development of more larger studies. Some questions are, given the number of patients is so small, is it simply that there was a difference between groups, but the study was not powered enough to detect this difference? And given the high dropout rate, although it was explained as due primarily to caretaker availability, could there be other factors? Here's the conclusion by the researchers. Quote, there was also a robust improvement in both groups in most measures from baseline to the 4 and 8 week assessments, but between group differences were no longer significant at the 8-week assessment. 4 weeks of chiropractic plus PT resulted in statistically significant improvements in motor function compared with sham plus PT in people with subacute or chronic stroke. These improvements appear to be clinically important, unquote. So the concern is how the results of this study are going to be portrayed in the media. Here are 3 examples. New study proves chiropractic cures stroke. Well, clearly that's an extrapolation and not true. Here's another. New study results indicate chiropractic coupled with PT care helps stroke patients. This is partly true, but not really giving the entire story. A longer headline might include, new study results indicate that the addition of chiropractic care to PT care for stroke patients improved mainly lower extremity function more than PT care only at 1 month, but not after. Obviously not as exciting, but certainly a more honest portrayal. The researchers should be applauded for their attempt, and this should serve as the seminal work for more larger studies.